Good morning, everyone. Welcome. It's 10 a.m. We're going to go ahead and get started today. My name is Ryan Green, and I'd like to thank all of you for joining us here this morning for our 2017 Medicare Update webinar. We're excited today to have Karl Steinlage with us. He's an independent broker with Steinlage Insurance Agency and is licensed in 12 states. He's got a bit of a specialization in the area of Medicare. And he's, like I said, licensed in 12 states. He's got his bachelor's and master's both from St. Louis University and has been working at the agency full-time since 2006. When he's not working, his son Jack, who is 5, and his daughter Tessa, who is 1, keep him plenty busy. As most of you know, Medicare is complex, confusing, and is ever-changing, and it's really an area where I think we could all use just a little bit of help. And based on some of the feedback that we've received from some of our clients that Karl's been able to work with, he's quickly becoming a great friend of the firm and our clients. So today, Karl's goal is to go over some important considerations related to Medicare, as well as to review some meaningful changes for the upcoming year. Before we move into today's material, though, I would like to note that you should see a text box over on the right-hand side of your page, which would allow you to enter any questions that you may have for Karl. And we'll try to reserve some time at the end of today's material so we can answer those questions. So if anything's on your mind, don't be shy. Get that question typed in there, and we'll do our best to try to get an answer for you. So with that out of the way, and without further delay, I'd like to go ahead and introduce Karl.
Thank you, Ryan. Good morning, everybody. It's a pleasure to be back for our second webinar. And as Ryan indicated, I work with my family's agency, and we specialize in the Medicare world. And today what I want to do is just kind of give you guys a brief update on some changes, touch on an important time frame, which is happening right now, called the annual enrollment period, and then maybe give you a couple of best strategies, best practices to use to look at your current coverage and make any tweaks, or just make sure that you're not missing anything to ensure a smooth transition into next year. So we are right in the middle of the annual enrollment period, and as everybody hopefully knows, this year the annual enrollment period is from October 15th through December 7th, and at this time, what you're able to do is review your Medicare Part D plan or Medicare Advantage plan and make any changes for the following year. A couple of suggestions that I would make is each company sends you what's called a formulary or list of medications, and those lists can change year to year. And my advice to all my clients, and you as well, is to just take a few minutes, flip through that formulary, make sure that all of your current medications are still covered, and if not, that kind of gives you an idea of maybe you should be looking at a different plan. A really good example this year that I see is there's a cholesterol medication called Crestor, which is generic, and what I found as I reviewed different Medicare drug plans and clients who are taking the generic is there is a wide swing in variety of copays, whether the generic or branded version is covered, and I have found a lot of people are on a plan that maybe that drug is not covered favorably, and by reviewing it for them, I've been able to switch them or save them sometimes hundreds of thousands of dollars just by aligning their drug list to the correct plan. So if anybody's taking Crestor, I would encourage you to, whether it's a branded or generic version, just maybe have a little more urgency or a extra look this year because of that drug going generic. And then any change you make begins January 1st of the following year. If you have a Medicare Advantage plan, which are private companies that contract with the government, your chance to switch back to original Medicare and a supplement is right now. However, one thing I would point out is if you go to Medicare Advantage and you do want to move back to Medicare and a supplement, you do have to answer health questions. So it's not a guarantee that you can get back onto a more comprehensive plan. So this slide is a great visual of everybody's decision within Medicare. So whether you live in Missouri, Florida, an urban area, a rural area, everybody has the same basic path that they have to pick to receive their Medicare benefits through. And on the left-hand side, that is the path that I find most clients lean towards, and that's showing your red, white, and blue Medicare card plus a Medicare supplement card and a prescription drug card. And the main component that you want to review there is your prescription plan, and then also your Medicare supplement policy, which we'll get into in a little bit, has some opportunities maybe to reduce your premiums while keeping you with identical benefits. The right-hand side is the Medicare Advantage world, and these are private companies like Coventry or Medicare Complete with AARP and United Healthcare. And what happens is these companies contract locally and take over or replace original Medicare. So you still have your Medicare benefits, your hospitals and your doctors. You still have to pay the Medicare premium, but you're receiving all of your benefits locally through a private plan. And Medicare Advantage plans can be attractive for people because they do have very low or no plan premiums, but they come with some potential gotchas. And the biggest ones are you are restricted to a network, usually within around a 100-mile radius of where you live, whereas Medicare and a supplement does not restrict you whatsoever. So sometimes if you get sick on Medicare Advantage, you might butt into that hurdle of a doctor who you want to go see might not participate in your plan. Or if you travel or carry dual residences, Medicare Advantage limitations can sometimes really bite you if the stars align and you need to access non-emergency care outside of that network. The other unattractive thing with Medicare Advantage is that those plans simply recreate the 80% coverage that Medicare has. So they don't supplement Medicare, which covers the 20%. Rather, they just give you the 80%, and then they charge you copays, hospitalization fees, 20% charges for things like cancer treatment or an MRI or rehab after a knee replacement, stuff like that. So I always find I get a lot of questions from clients who are on the left-hand side with Medicare and a supplement, maybe paying $150 to $200 a month, thinking maybe the grass is greener on the other side with Medicare Advantage. But the thing you have to watch out for is if you get sick, Medicare Advantage can be more expensive given the copays limiting. And then if you decide later on, after you've realized maybe it's not as attractive as you hoped, to move back to the other side, depending on your health history or your age, it can be unobtainable or much more expensive given the situation. So Medicare Advantage does have a time and a place, but I would just caution you on thinking that the grass is greener totally on the other side, because there are some potential landmines or issues that can occur. So I'm going to jump into one of the newer things that has happened. This is a new law, and to try to glance over this but not get too technical. In 2015, a law was passed that was known as the Doc Fix Law. And up until this point, what had happened is every year Medicare would pay physicians based off of this sustainable growth rate formula. And long story short, what it would do is it would cut reimbursements to doctors, which then doctors came back to Medicare and said, if you cut our fees for office visits and testing and lab services, then doctors might drop out of Medicare. And every year for the last 15 to 17 years, Congress has basically just passed this on to, okay, we'll look at it next year. We won't cut your reimbursements, but we'll look at it next year, and we'll look at it the following year. Until finally in 2015, that cut had grown to 21%. Well, there was a change in the way that physicians would be compensated. And while that is definitely important, there are three main areas that I find the sustainable growth rate or the Doc Fix Law is really going to affect people sooner rather than later. And to finalize that thought, payments and reimbursements with Medicare today and into the future are now going to be more closely tied to the quality of care. Whereas prior to this, a new physician just graduating from med school or an orthopedic doctor who had worse outcomes than another orthopedic doctor, Medicare always paid them the same amount. And now we're seeing this change of doctors who are doing a better job, providing better care at a lower price, are going to be rewarded for that. That will affect us eventually, but I think it's a slow-moving ship and is not the focus of what I'm going to talk about. However, there were three main areas that the doc fix law will affect you sooner rather than later. The first is this acronym IRMAA, I-R-M-A-A, and that stands for the Income-Related Medicare Adjusted Amount. What the doc fix law did is it changed the reimbursement or the payment model for your Medicare Part B premium. It also removes Social Security numbers from Medicare cards. So in the next couple of years, everybody's going to see a change in their Medicare card. No longer will we use that red, white, and blue card with your Social Security number on there. There will be some sort of new card which has not yet been announced or shown, but I imagine it will look a lot like your former employer ID card with a random generated number on it. And then finally, Medicare Supplement Plan F, which up until the last couple of years was easily the most popular Medicare supplement plan sold. And an easy way to know if you have Plan F today is if you show your Medicare card and your supplemental card and you pay no copay, no deductible, no out-of-pocket costs whatsoever for the whole year, you probably have Plan F. Plan F will be grandfathered in, but is going to be eliminated as far as new sales of Medicare Supplement Plan F in 2020. So clients who have Plan F would be grandfathered, but they would be subject to future rate adjustments. So starting with the IRMAA or income adjustment, the change with this occurs in 2018. And in a nutshell, what the doc fix law will do is it's going to push more clients into these brackets by reducing future inflation adjustments to the brackets and then moving more people into the higher surcharge area. So if we look at this first line, you can see that an individual person making $160,000 would pay a 65% surcharge. In 2018, if you go down to the bottom line, you can see that same person now would be responsible for an additional 15%. And this is on your Medicare Part B premium and Medicare Part D income adjustment. And this happens only if a person's adjusted gross income is $85,000 for an individual or $170,000 for a husband and wife. If you're under that threshold, this doesn't affect you at all. But one of the things that has changed is these top income thresholds, the 85 to 107, 107 to 133, those are no longer going to increase over time. Rather, they're going to stay the same. So as you have these cost of living adjustments or pension increases or realized capital gains, your income might increase to put you into that bracket. You might find yourself more likely to receive an income adjustment. And these income adjustments can range anywhere from about $50 a month on top of your base Medicare premium, all the way up to about $600 a month for a husband and wife making over about $500,000 a year. So depending on where you're at, it can be pretty pricey. In certain situations, there's nothing you can do about it. As Ryan and I were talking earlier, if your pension and your Social Security and your required minimum distribution all add up to $200,000, there's probably no way that you're going to be able to get that number below 170. So it might just be something that is affecting you whether you like it or not. However, for some people on the fringe, there might be some strategies that you can look at to try to eliminate or reduce the exposure of this income adjustment. And the way that you do that is you actually can appeal the decision. And the reason for that is because Social Security and Medicare actually use a 2-year look back. So a common situation that I see is a new retiree. So let's say you retired at 63 and you were making $200,000. Now, 2 years later, you retire, but your income has been reduced because you're not working. Medicare will look at your income from 2 years ago to determine what your Medicare premium is today. What you can do is you can actually appeal that decision and provide documentation of retiree letter or loss of work if that's the case, or if you sold a business, cut back hours, sold stock, or had some other one-time event that caused your income to be higher in a certain year, you can appeal the income adjustment with Medicare. And this link right here is a link to the Social Security website. It's a really easy process to, and I'll see if I can open it real quick if that's okay, and show you the document. We're in uncharted territory here, so we'll see if this opens. And if it doesn't, it's about a 5-page document. It's real straightforward. It's something that I've helped many clients with, and I find it has about a 50-50 success rate. And the advice I always give clients is you have one shot at this, so over-document and try to show the government as much proof of your situation as possible. Maybe writing a cover letter, just in layman's terms, explaining your situation, showing a previous tax return that had lower income if that's possible. The next situation that the DocFix law affects clients is with Medicare supplement plans. So hopefully everybody has seen this chart before, because whether you're in Missouri or Florida or California, every Medicare supplement company is required to offer you a standardized lettered policy. And usually the lettered plan is shown on your ID card. Another way you can find out what lettered plan you have is to call the company and ask them. Or if you still have your policy, which I find most people don't have, on your schedule page, it will show very clearly what lettered policy you purchased. I find that the vast majority, if you polled 10 or 20 of your closest relatives, mom, dad, brother, sister, neighbors, I would bet that 7 out of 10 of them all have Plan F. And the reason for that is it's the easiest to explain. It's also the most common plan, so many insurers sell Plan F, whereas not as many sell Plan G or N, which are 2 of the newer plans or more popular plans recently. But what's happening in 2020 is nobody will be able to purchase Plan F at that time. And the reason for that is because Plan F covers the Part B deductible and is considered first dollar coverage. And the thought is that plans that cover 100% tend to have overutilization, meaning that if you have no out-of-pocket costs whatsoever, you're more inclined to go have additional testing or additional doctor visits. A good example I can think of is if your car insurance paid for maintenance things like new tires or new belts or fluid flushes, we would all be more inclined to go have all those things done when someone recommends it because there's nothing out of my pocket. Whereas if my brake fluid flush is $100, I might be a little less on board with having that changed every time a mechanic suggests it. So with Plan F, you kind of get that same effect or concept, is that since nothing is out of your pocket, Medicare believes that people on Plan F have additional expenses that if they had to pay co-pays or a small deductible, that might prohibit them from having those services done. And a great real-world example of this, I was reading the Wall Street Journal this morning, and there was an article in there that said Medicare spent $359 million in 2013 on unnecessary chiropractic care. And in my mind, I think of, with my insurance, it costs me $40 to go see a chiropractor. So if that chiropractor wants me to come in every single week, whether it's medically necessary or not, in my mind, I have to spend $40 to go see that doctor. If I have Plan F and everything's covered, I might be much more willing to just go have that treatment provided because it feels good, or it, provides some marginal benefit, uh, but then nothing comes out of my pocket. So with Plan F, the concern that is there is with no new people getting onto Plan F, you can have rate increases and an aging of that block of business happen faster than Plan G or Plan N or some of these open blocks of business. The way that a company rates their products and the price that you pay is based off of the lettered plan, the issuing company, and the state that you live in. So I'll give you an example. In Missouri, United Healthcare with AARP is a really popular plan for Plan F. It's also really popular in Florida. And once Plan F is no longer sold, United Healthcare won't be able to add that 65-year-old or 66-year-old. The newer, younger person would be deflected and move into either a different insurer or a different lettered plan. So as that occurs more and more, the age or average age of everybody in Missouri on Plan F with United Healthcare gets older. And as that average age increases, the claims experience and the outlay that the plan pays goes up. And as the claims go up, your premium tends to rise faster than a plan that's bringing in new people. So one benefit that I have had really good success with in response to this change that's coming is to consider Plan G or Plan N instead of Plan F. And the reason for that is kind of exactly what I just said, is that Plan G, you get a healthier block of business. So you get people who leave retiree plans or leave Medicare Advantage plans, if they can qualify health-wise to get into Plan G, they have lower claims experience and therefore lower premiums and lower rate adjustments year to year. And the only difference between G and F is the Part B deductible. The Part B deductible for 2016 is $166. So that same person who has knee replacement or a hospital stay or cancer treatment, if they have Plan G, the only difference between F and G is $166 per year benefit. You can see all of the same doctors. You have all of the same comprehensiveness as Plan F with hospitalizations, with long-term care or nursing home rehab, MRIs, physical therapy, seeing as many specialists as necessary. So there is literally no difference between F and G other than the premium that you pay and then also that $166 per year deductible. A lot of times what I found is that clients can save sometimes $1,000, $1,200 a year in premium by switching to Plan G. They pay that small deductible out of pocket and they come out ahead. The same effect can occur with Plan N. The only difference between F and N, besides that deductible, is Plan N then also charges you an office visit of $20 and a $50 emergency room visit. So again, the concept here is that you'll take on a little bit of risk, you'll pay a small deductible, all the big stuff is covered at 100% with F, G, and N. But switching from F to N or F to G might be a really easy way to not reinvent the wheel, but provide you with significant savings, still cover yourself comprehensively, provide all the same access to doctors and hospitals that you have with Plan F, but save enough money to consider doing it. And that would be something that I could help clients with, looking at the pros and cons of switching from F to G, looking at different insurers in different states and giving you recommendations on who has the best rate given your zip code, your health status, your current insurance, and all other variables as well. So in St. Louis, a sample that I could give you is for a 65 female, Plan F is about $175 a month, Plan G is about $130. So that person would save about $60 or $600 a year in premium and just pay out that one-time deductible. They would come out ahead with Plan G. One key thing to just also reiterate on is if you have Plan F, because it's going away, you're not dropped from that plan. So if you have Plan F and it's a good deal for you, you can keep it, and regardless of what happens later on, all Medicare supplement plans, whether it's F, G, or N, are guaranteed renewable for life, meaning that as long as you pay your premium, the company can never drop you, regardless of what happens externally. Another thing that I have had great success with is providing a review for clients on an annual basis. And the reason for this is to make sure that nothing falls through the cracks and make sure that you're not leaving low-hanging fruit or easy money on the table. And whether that's looking at your Medicare supplement to make sure you're in the best possible spot cost-wise, or looking at your Medicare Part D plan to make sure all of your medications, your preferred pharmacy, your mail order benefits are all still intact. A really easy way to do that is with this annual review. So with this link is a document that pretty much houses all of the information that I would need. List of doctors, list of medications, information on your current plan, and then I can go and shop the market for you and make recommendations whether it makes sense to switch, or what a lot of people like is just that reassurance that you're in the right spot. You get all this mail and all this inundation of United and Coventry and Blue Cross and Blue Shield all saying, hey, you got to switch, your plan is no good anymore, look at ours. Well, people just like that reassurance that you're not missing anything, that you're in a good spot, no surprises, and that's what this review can do. So one of the things I wanted to highlight is everybody across the country should get this Medicare and You handbook. And if you haven't got it yet, it's probably buried in all of the other mail, or possibly you threw it away, put it on top of the fridge on the to-do pile later. There's a couple of pieces of information in here that I wanted to highlight, and it's in the very back of the book. So not only do you have to know where the book is, you also have to get all the way through the 150 pages to find what I think is the most valuable piece of this. And what it is it's an alphabetical list of every Medicare drug plan available to you in the state. So I pulled this one from my secretary, who is 65, and she's in Missouri. And what you see here is you see all of the prices that the Medicare drug companies charge. You'll see Aetna at $26.50, which has been a really popular plan for clients for next year. You see Blue Cross and Blue Shield with premiums of $65, $107, $149. Cigna at different pricing. Some other companies, Express Scripts is kind of one of the newer plans at $51 and $83 a month. First Health is a really popular one. Humana is the lowest plan premium in Missouri and pretty much across the country. They have a Humana Walmart drug plan that's $17 a month. And so the next question I always get is, if Humana charges $17 and Blue Cross charges $149, isn't Blue Cross more comprehensive or a better plan? And I always joke that there is no logic in Medicare Part D whatsoever. And to go back to that drug Crestor, a good example is that the Humana Walmart plan covers the generic Crestor for next year for about $12 a month. So if you have the generic Crestor 10 milligrams, your copay at the pharmacy next year would be about $12 a month. On one of these Blue Cross plans, they still have the branded Crestor. So you're not paying $11, you're paying a brand name copay, which is usually $40 to $60 per month. So again, no logic on would a $150 drug plan be 10 times as good as a $15 a month drug plan. And if you're analytical like I am, sometimes you struggle with the rationale of, why is a lower plan maybe more comprehensive or a better fit. And this is really all about just matching your drug list to the specific plan that fits you the best. And that's a service that I provide clients initially and on an ongoing basis. So you would get a document from me each year asking for a drug list. And what we do is we go into Medicare's website and we search all 20 or 30 drug plans for you. We review the changes in your current plan, not only with premium, but to make sure that all of your medications are covered. Your preferred pharmacy is still a preferred or allowable pharmacy. We look at all of the different changes, not only on the surface, but also under the hood to make sure that you're not missing anything. And if you are, maybe a switch from Blue Cross to Humana can save you $1,000 a year or so. I'll make that recommendation and kind of give you the tools to say, here's why I think you should change, and here's where some of that savings comes from. And this is a really valuable service that a lot of clients appreciate because you don't really know where to turn, but the information is right in your mailbox, and unfortunately it's at the back of the book, and not a lot of people realize that all of this info is available to you. One of the big things this year that I have noticed, and it's made national headlines, has been the consolidation of health insurers. And we might have a little bit of change in this as Aetna tries to purchase Humana and Anthem, Blue Cross, and Blue Shield tries to purchase Cigna. And there seems to be some back and forth between the Department of Justice and these insurers about whether that is going to be allowed. But this is a great graphic. Medicare Part D came out in 2006. And like a lot of new industries, it took a year or two for insurers to realize the attractiveness or figure out how to make a dollar off of it. But once that happened, you can see in 2009 and 10, the number of plan choices to you spiked. And we've been in a steady decline over the last 7 or 8 years for 2 or 3 reasons. One has been consolidation, and 2 has been the internal changes that these plans have made year to year. And what I mean by that is I'll use United Healthcare again because they're a name that a lot of people know. They're also really popular, especially back in the beginning of Medicare Part D. So I find a lot of clients have bought their drug plan in 2006, 7, 8, 9 when they first got onto this, and then they haven't looked at it since. And insurers kind of know that people do that. I've read some statistics that say only about 10 to 12% of people on Medicare proactively change their plan. And a great example that I use is buying cable or buying DirecTV. I moved this year, so I'm a great example. When we moved, I researched the heck out of DirecTV and Charter and, negotiated back and forth, and I did all this homework last year thinking I have a good deal, and I do, but eventually those perks and those teaser rates and those benefits start to water away, and after 3 or 4 years, I'm not paying $100 a month with free HBO and the NFL Network. I'm paying $220, and I don't have those perks. And the Medicare drug plans, I think, kind of know that as well, is they give away the plan the first year, or offer a very competitive low-priced plan with a lot of the popular drugs covered favorably, but then they start to have rate increases, they change the tiering or a combination of all of those things. And I would think of it very similar to your employer plans, if this is an appropriate analogy, is every 3 to 5 years, 7 years, it was common for your company to just rebid its insurance to make sure they're in a good spot. Where the insurers have to price their plans competitively to win the business, but then they come up with these new plans or they start to have rate increases, so they advertise to new potential members this new low rate, but they don't tell the existing members who are in the higher price plan to switch over. You're kind of left to do that on your own. So two specific examples I would give you, and these are true especially the last couple of years, a merger and consolidation. At one time, Express Scripts and Medco were two separate entities. And back in 2010 or 11, part of the reason why there was 46 plans compared to 22 is Express Scripts had one or two standalone drug plans, and Medco had 2 or 3 separate standalone drug plans. Well, a year or so ago, Express Scripts purchased Medco. And when that happened, they didn't keep the 5 plans. They consolidated the 5 into the 2 Express Scripts plans that if you look back on the back of the Medicare book, you saw those 2 Express Scripts plans. What has happened is Medco, being Company B, when they get bought out by Express Scripts, Medicare allows Express Scripts to map those Medco clients into an Express Scripts plan. And wouldn't you know it, they don't map you into their most competitive offering. Usually they map you into the most expensive plan that they offer. So if you had done all this homework 4 years ago and found that the low price Medco plan was the right fit for you, and you haven't looked at it, you've now been transitioned into the more expensive Express Scripts plan. And a lot of times, not only do you have higher premiums, and these premiums usually either come out of a checking account or a Social Security check before it's deposited into your account. And it's just one of those out of sight, out of mind things that you might not even realize that your premium has gone from $20 or $30 a month up to $75. That you now have a $400 deductible on your Medicare drug plan and you didn't 2 years ago. And then your copays went from $10 to $35. So when you add all of those changes up, that's where you can find a new plan at a lower premium with no deductible and much lower copays can save you $1,000 a year, give or take, depending on your situation. So the merger and consolidation of Medicare Part D, I find, has affected people a lot, especially when you look at the big companies. 2 other companies this year that merged, there was a Medicare drug plan called United American that was really popular with CVS pharmacies. Well, wouldn't you know it, CVS, which owns a company called CVS owns a company called SilverScript, purchased United American, and SilverScript mapped them into their higher priced plan. So if anybody has a United American plan, you should have received information that it is being mapped into SilverScript for 2017. Another way that this can affect you is a plan can non-renew one of its offerings and then shuffle the deck to move those people who bought the lower priced plan 4 or 5 years ago into their medium or higher priced plan, and then come out with this new plan that they market to potential enrollees. A great example of this for 2017 is the AARP United Healthcare Plan. Back in 2011, they had the Saver Plus, Preferred, and Enhanced plan. The Enhanced plan non-renewed, pushing those people into the Preferred plan, but now the low and middle plan for next year become the medium and high plan. And then they market this new ARP Walgreens plan that you might see advertised with a really low premium and really aggressive copays at Walgreens. I'm finding that I'm moving a lot of clients internally from ARP Preferred to ARP Walgreens, and it's saving them $800, $900 a year because you're going from $75 a month down to $20 with $0 copays on generic drugs at Walgreens. So these are just some of the things that happen behind the scenes. Hopefully I didn't get too deep in the woods there and muddy the water, but the end result is that you have less options. If you don't review this on a proactive basis, you might find yourself just being shuffled into these higher price plans and not realizing the savings that is sitting right there. The tool that I use and is available to everybody is the Medicare.gov Plan Finder. Great tool, unbiased spot to go in, and what we do is I take that drug list, type in your zip code. So one of the key things I wanted to reiterate is we're licensed in 12 states, but I can do this for you as a value-added service regardless of where you live. And in fairness, anybody can do it themselves. You just go to Medicare.gov, type in your zip code, and kind of follow the prompts. But this is the tool that solves for all of the variables, your premiums, your copays, the donut hole, and it spits out a nice round number of your annual expense. And then we review that with what you have on your current plan to what a more competitive plan might be. A couple of miscellaneous things. Social Security finally announced a nominal cost of living adjustment for 2017 of 0.3%. So everybody should get a free cup of coffee for next year with your cost of living adjustment. How that might affect more people negatively is there's a whole science behind the cost of living adjustment and the rise in your Medicare Part B premium. And to simplify that, the way it works is you cannot have a net decrease in your Social Security check. So if your Social Security check is $1,000 and your Medicare premium is $104.90, which is what a lot of I would say anybody over maybe age 70 is probably paying $104.90. The new to Medicare people in the last couple of years are paying $121.80. And the reason for that is the older people who have been on Social Security didn't get a cost of living adjustment, so their Medicare premium couldn't rise. And when their Medicare premium doesn't rise, the new people have to offset that by paying a higher premium. And that's called a hold harmless provision. So when you have very low or no cost of living adjustments, it really hits these three people, the new to Medicare beneficiary, the client on Medicare but not drawing Social Security, and those clients subject to the income adjustment in a puts them in a worse situation because those older people who are on Medicare and Social, they can't have a rise in their Medicare premium to help offset rising costs. So more of that expense is pushed onto these three groups. And unfortunately, there's not a lot, if you're born in 1952, you're turning 65 in 2017. There's not a lot you can do about that, but it's just something to be aware of. As cost of living adjustments increase, what will happen is the 104.90 people will move up, and possibly the people paying a higher amount will either decrease or not have an adjustment to where eventually those numbers will kind of stabilize. This has happened in the past, but it's just something to be aware of with a nominal cost of living adjustment at 0.3%. Typically, Congress would pass some sort of temporary measure to kind of, fix this later on. At this moment, the Part B premium and the Part B deductible have not been announced for 2017. But also going back to the F versus G comparison, the Part B deductible can only rise at a percentage similar to the cost of living adjustment. So that prevents that $166 deductible from shooting to $500 or $1,000 because it's limited to how much it can go up based off of your cost of living adjustment. So I always kid that if the Part B deductible went through the roof, you would love it because that means your Social Security check would go through the roof as well. And then consequentially, if the deductible increases a lot, Plan F, which covers that deductible, is going to have a pretty high adjustment to offset for the fact that they now pay for a much higher deductible. So in summary, the things I wanted to just kind of highlight is this doc fix law, which went into effect last year, will have three main areas that might affect you. The change in the income adjustment, which starts at 85,000 or 170,000 of modified adjusted gross income, is going to freeze. So more and more people are going to fall into that to help offset some of the additional expenses that Medicare has had. Plan F is going to non-renew or not be sold to new people in 2020. And then the Medicare card is going to get a facelift here in the next 3 to 5 years. I would highly suggest that people look at Plan G and also Plan N because it's very much an apples to apples comparison. As long as you have Medicare primary along with F, G, or N, you would be extremely satisfied with how comprehensive your coverage is, the freedom and flexibility to pick any doctor in the country, and I find that G and N will provide pretty substantial premium savings as well as more stable rate adjustments year to year because of the changes in the grandfathering of the Plan F block of business. I would encourage you also to reach out for a free review. It's a really simple process. It can save you money, provide a smooth transition into next year, and really just make sure you're not missing anything or leaving anything on the table. A common frustration I get is a phone call in January or February when you go get your prescriptions refilled and Walgreens isn't a preferred pharmacy. So they say, sorry, if you get your scripts filled today, it's $400, and you walk out of there frustrated, wasting time, wondering why you can't go to Walgreens when that's your preferred pharmacy, or with the Crestor example, your drug has now shot up substantially. A set of eyeballs on this, just make sure that you're not missing anything, and I can do that for you year in and year out at no cost to you. So in conclusion, I really want to thank Ryan and the Brand Asset Management Group for inviting me in for our second webinar, and at this time I would open it up to any questions that anybody has or follow-up. Thank you.
Yes, thank you, Karl. As always, great information. I think if there's one critical takeaway that at least I've picked up from today's material, it is that there is no universal answer when it comes to Medicare. That optimal solution for everybody is going to be individual and based on several variables. You know, what doctors do you like to see? What medications do you take? And with the inundation of materials that invariably come this time of year that show up in your mailbox, I can see where people would have a difficult time trying to determine, well, which in the world one of these options is the best for me. Oh, and then on top of that, it's going to change sometimes annually. So finding that right solution is really something that does need that customized touch, which is why we feel that service that Karl can offer to our clients is just so valuable. As Karl mentioned, we do have some questions here that we're going to go ahead and move through. We've still got some time out there. If you all are chewing on a question and you want to have Karl attempt to try to answer that, go ahead and get that typed into that text box. But we'll go ahead and start with the first one here. It's kind of a two-part question. So Karl, the question is that the current enrollment period is for those that are at least 65 years of age by January 1st, and if that is the case, second part of that question is, what if they turn 65 later on in the year?
So when somebody turns 65, you actually have what's called your initial enrollment period, and that is a time 3 months before so Medicare always starts the first day of the month that you turn 65. So if your birthday is, like mine's June 27th, my Medicare benefits would begin June 1st. If your birthday is on the first of the month, so June 1st, and your Medicare benefits begin on May 1st. So you have this time frame 3 months before or after to prepare and enroll into Medicare. And if you're not drawing Social Security, which is more and more common, you actually have to enroll into Medicare. The easiest way to do that is to go to Social Security's website, ssa.gov, click on the menu, go to Medicare, apply for Medicare only. You can do that in under 5 minutes. But if you don't apply and enroll in a Medicare A and B before your 65th birthday, about 90 days before, you hit some snags as far as getting your insurance lined up at the correct time frame. But the annual enrollment period is actually not affecting you today. If you have a spouse who's over 65 and they're already on Medicare, then they would be subject to this October 15th through December 7th cutoff. You would have that 90-day window before or after your birth month to kind of gear up and figure out what you need to do at that time. And that would certainly be a process that I could advise and guide you on from A to Z as far as enrolling into Medicare, making sure you do that properly, and then helping you figure out the appropriate plans for your situation.
Thank you. We've got another question here. So as it relates to the new Medicare card, are they still going to use the Social Security number on that card?
They're not. They are going to use, last time I read and checked, they haven't come out with a template of what it's going to look like, but it will be a random generated number. And the reason for that is the medical identity theft, when it's tied to your Social Security number. If somebody steals your Medicare card, today you can't go cancel it out like you can a credit card because it's your Social Security number. So the ability to stop fraud after someone has stolen your identity is really difficult because that Medicare claim number is your social. So it will be some sort of alpha numerical number, much like if you look on, say, your Medicare Part D card, that number is usually a 7 to 15-digit number that has no bearing to your social whatsoever. One thing I would just hint on is I'm sure there's going to be scams galore as far as people calling you saying they need your social to send you your new Medicare card. Obviously don't fall. Medicare would never call you on the phone, and it would be something that would all be facilitated through the mail. Typically Medicare would just send it to you, and this will gain more traction as it gets closer and closer, but under no situation would Medicare call you or ask for your Social Security number to send you your new Medicare card.
So a lot of times we'll work with clients that have healthcare coverage that extended from their prior employer. You think of the classic situation where the husband worked at General Motors for 40 years and they sent him on his way with his gold watch and extended retirement coverage for healthcare on into retirement. In your experience, Karl, do you find that those types of coverages offered by some of those big corporations in retirement are more attractive than what they could get in the open marketplace, less attractive, comparable situation to situation? How do you feel about that?
That's a situation that has become more and more common as companies either get in trouble financially or mergers occur. We were talking about Bayer buying out Monsanto earlier this morning, and just the consequence of what happens to retiree healthcare. InBev purchasing Anheuser-Busch, AT&T, local school districts, local unions. A lot of times what these companies are doing is they've drawn lines in the sand of saying our retiree healthcare costs are so expensive because you have same effect as like the Plan F is, let's use AT&T for example. Their retiree group is a defined group of about 300,000 people across the country, and everybody is getting older. There are no new retirees buying in or getting into that group because of changes that AT&T has made internally, saying if you worked here from 1975 and on, you don't get benefits. So those people born later in life are deflected. And so the point I would make is more and more commonly retiree plans are just pushing all of the cost increases onto retirees. The employer is not subsidizing additional premiums, and more people are realizing that what they've been trained and told and thought for all these years, that the employer world provides more negotiation, and the group of 100,000 people can go negotiate a better deal than what I could on my own, is not true. And not to say that that's a universal truth, but I will say that it is more and more common for retirees to kind of realize what their friends who don't have retiree medical are saying is true, is that these plans, they give you just a very general comparison. If you're a 70-year-old female in St. Louis, you can buy a Plan G for about $150 a month and a drug plan for about $30 a month. So you could pay, you still pay your Medicare premium, and you could even add dental to that for say another 30. You could pay about $200 a month away from your retiree plan, and you have full coverage, the ability to go to any doctor, very little, if any, out-of-pocket cost, no copays to see the, no referrals, and you compare that to like what some retirees are paying, 400, 500, 600 bucks a month. You kind of scratch your head and think, what am I missing? And so it's really just been a change in thinking and philosophy. Again, that's not a universal truth, but more and more I'm finding retirees are kind of coming out of the woods realizing that, hey, this retiree plan that has gone up significantly, or if I'm being kicked off of the retiree plan, where do I turn, or what does this other world look like? That's definitely something that has been a more common situation in the last few years.
Thank you. So another question here is that as we've talked about this and the variables that go into finding the right solution for clients, Karl, you've mentioned an analysis where you gather information and use those inputs to provide a level of analysis and recommendation. What is the fee associated with that, or what's the compensation structure?
So I don't charge any fees to assist clients, and I receive commissions from the insurance company that you choose. So an example would be if we go back to like this slide that shows the Medicare drug plans, that Aetna plan I referenced at $26.50 a month. If you bought that plan through me, Aetna would pay me a commission. And one of the things I love about the Medicare space and what I've really prided our agency on is truly being independent. So I actually go out to every one of these companies, Aetna, Blue Cross, Cigna, and I take all of the annual certification and all of the renewal training to be able to sit down with a client and say, I represent every Medicare Advantage company in St. Louis. I represent every Medicare drug company, and those companies all pay me a commission based off of me matching you with that plan, but that results in no additional cost to you. Aetna is $26.50 whether you go online and do it, whether you go to Medicare.gov or buy it through me. So I don't charge any type of fees. There's no hourly, expense that I charge you. And even if it's just an acknowledgement that you're in a good spot, I've done this long enough to realize that, I might not be able to help you, but that could change year to year. Or you might have a girlfriend or a brother who's turning 65 and they need guidance and I can help them. So I certainly don't mind giving people advice because I know it's going to come back and benefit me in the long run. But to answer your question, I receive a commission from whatever insurance company you would pick, whether it's United or Coventry or whoever, and that's how we receive our commission or compensation. And I would also point out that I receive that compensation on an ongoing basis. So my incentive is to work with clients not for the first year, but as long as we're all around, because I would get a lot more from a satisfied client by keeping them out of trouble for 10 or 12 years than trying to, pick the most expensive plan for a year because that's how, I would get paid more or whatever. So my incentives are aligned to I want to work with people in the long run and providing that guidance on an annual or as needed basis.
Thank you. I'd just maybe tack on to that by saying that kind of quite simply, the goal here is to either save you money on your premiums, find you better coverage, or a combination of those two. And if Karl's not able to do that, I think you still win by just having some degree of comfort that, you know what, we've gone out and shopped everything that's available to us, and what we've got's the best for our needs. So there's really a win no matter how you look at that. Oh, and by the way, Karl doesn't charge anything for that analysis. I think you can see why he's become such a good friend to us around here and why we encourage so many people to talk to him. Another quick question. We have quite a few clients down in the great state of Florida. Are you licensed to be able to help them?
I am. About 3 or 4 years ago, I just had a a number of clients who relocated from Missouri to the Naples, Fort Myers area. So at that time, I just decided to go get licensed, and I'm fully licensed in Florida to offer Medicare supplements, Medicare drug plans, etc.
Wonderful. With that, then, I think we have just about run out of time here. Karl, thank you again so much for joining us today. It's been wonderful to have you share this information with us. Thanks to everyone listening out there. Great to have you on board with us today as well as we move through some of this material. The presentation materials that you've seen has Karl's contact information, so if you had a question that you get a chance to ask or didn't get an answer to it, or if you're interested in working with Karl to try to determine if you do have an optimal insurance solution as it relates to Medicare, please feel free to give him a call. He'd be more than happy to talk to you. I think that just about does it for today. Again, thank you everyone for joining us, and I will talk to you later.
Thank you. Everybody have a good afternoon.